physical assessment, TTBS, and palpation.
We have with us today a model patient who's presenting with local TMJ discomfort with some clicking and who reports of headaches on her left side. So after having gone through where's your area of pain, what are aggravating factors, what are some relieving factors, I go through this basic scan. The first part of the scan is called TTBS. What does the T stand for? Tongue. What's the second T? Teeth. What's the second T? B is for breathing and S is for swallowing. Let's start with this. Now, don't move, sit there comfortably. I'm going to ask you a question. And tell me, right now, where is your tongue? Is it at the roof of the mouth or resting at the bottom of your mouth?
It's resting at the bottom.
So if they say resting at the bottom, I get a clue that they may be in excessive tone in their genioglossus muscle, which increases the tone in the rest of the facial muscles. Ideally, the tongue should be resting at the top of the mouth, or in the roof of the mouth, I should say, and behind the front teeth. Second T for teeth. Now, right now, as you're comfortably sitting there, are your back molars touching or are they apart?
They're apart.
So, which is a good thing, because if they were touching each other, that would tell me that she's clenching her teeth. And that obviously is a sign of bruxism, which is excessive clenching or grinding of the teeth. Next is for breathing, which I don't really ask, I just have to observe. As she's been sitting here, her lips have been closed. Sometimes people sit there and keep your mouth, they just have their mouth open the entire time as they're breathing. It may be related to blocked nostrils or whatever. However, mouth breathing is also a predisposing factor to TMJ pain. So TTBS, and the final S stands for swallowing. Now, I don't tell them what I expect because that will confound the findings. I palpate the trachea right here, and I palpate the posterior aspect of her neck in the suboccipital area. And I ask her, this is going to sound weird, can I just ask you to swallow your own saliva right now? Now, as she swallowed, I noticed that her head came forward and she has a slight cervical extension. It's most often more subtle than that. Can you do it again? Again? And in case you didn't see it, her neck went into extension as she swallowed. That is actually a common finding, people who have not only just TMJ issues, but also suboccipital headache. And that's basically related to every time they swallow, instead of using the digastric muscles, which are lengthened and weak, usually from a forward head posture, they're using their suboccipital muscles to extend their neck in order to assist their swallowing. Which means every time they eat food, every time they chew, and every time they drink anything, they're overusing their suboccipital muscles. No wonder they have suboccipital headaches. The next part of the assessment is the palpation. I'm going to go through this relatively quickly because I want to keep it simple. So the most common area that is tender is right there in the temporalis muscle. As I mentioned, there's three fibers. Anterior, which I'm telling you, is there a difference between your right side versus your left side?
Yes, there is.
What is it, do you feel?
The left side is more tender.
There's more tender. So that gives me an idea her temporalis may be overused, or she has some kind of trigger points or excessive tone in there. The middle fibers, how's that? Is that it?
Again,
So,
the left side is more tender.
how about back here?
It's still the same, left side.
Left
is
side.
tender.
Most often the anterior part is the most tender part. Next muscle I palpate is the masseter. So I palpate the right side. How does that feel?
That's fine.
And the left side?
That is tender.
Now, you often also feel a ropiness or excessive tone in that masseter muscle, which gives me a clue that she may be clenching excessively or laterally deviating a lot on that side, therefore increasing the tone of both the temporalis and the masseter muscle. The next muscle I'll palpate is indirectly the medial pterygoid. I find the angle of the mandible and I scoop underneath and I palpate it. And compare the right side, anything?
No, there isn't.
How about left side?
Yes, there is.
It's tender. That's quite tender, so you have to be very gentle. So basically, I scoop underneath the angle of the mandible and palpate it internally, so inside the mandible, which is often tender, which tells me that she may be clenching excessively here, and she may be doing excessive lateral glides or deviations, which is related to bruxism. Now, the lateral pterygoid, I palpate internally, which I won't be doing right now until I put the rubber gloves on where I get to the patient where I'm doing the actual intra-articular assessment. And the reason I avoid assessing the lateral pterygoid because it's extremely tender in people, and if you jump into it, you can really exacerbate people and they'll lose trust in you touching them. So now I'm going to go to the TMJ. Find the tragus of the ear, which is right there, and you go just anterior to the tragus ear, which is the common area for the TMJ. I'll palpate the right side. Anything?
No.
And then the left. How about left here?
Yes,
it's tender. Now open your mouth up as far as you can comfortably go, and then I repalpate. Is it better or worse?
It's slightly better.
Yeah. So most often people say when they open the mouth, it can actually feel worse. If it feels worse, that means they have capsulitis or the capsule has been irritated. The next part that I assess is the retrodiscal tissue, which is an indirect palpation, the RDT. I'm going to do something to you right now, Mitra. It's not the nicest thing to do, but I'm going to put my pinky inside your ears. Now, I use both pinkies inside the ears, and I'll palpate anteriorly. So I'll glide my pinky anteriorly, and I'll feel the right side. Anything?
No.
Compared to the?
Yes, it's sore.
It's sore. That's usually a sign that the RDT or the retrodiscal tissue is irritated. Now, open the mouth, and I'll do the palpation again. How about now? Better or worse?
It's slightly better.
Yeah. Most often, this is actually worse in people, meaning as the retrodiscal tissue gets lengthened during mouth opening, it feels worse. It exacerbates the patient's symptoms. And that's a clue that the patient has retrodiscitis. The second method of palpating the retrodiscal tissue is instead of approaching from an anterior view, which can be quite intimidating to the patient to face them and do this technique, is to approach it from behind, where you do have to get into this position where you insert the pinky into the ear and apply an anterior glide again. Compare the right to the left. Is that tender?
Yes.
Yes. Now open the mouth up and I'll apply an anterior glide again. How about now?
Yes, it's still tender.
So what I was doing simply is applying an anterior glider force through the tip of the fat pad of my distal phalanx, of my fifth phalanx.
Please pause the video and complete the section 1 of the physical assessment page in your workbook.